مين بيخبط؟ ايوه. مين على الباب؟ ايوه. مين؟ ايه ده؟ الدنيا ضلمة. ايه ده؟ ليه؟ الساعة كام؟ الساعة ايه ده؟ مين انت؟
مش عارف مين.
لا مش عارفك. انت اكيد جاي عشان تقتلني، اكيد. انا عملت لك حاجة؟ قول لي بس. انا عملت لك حاجة؟ مش هسمح لك اللي انت تقتلني. مش هسمح لك اللي انت تقتلني. مش هسمح لك اللي انت تقتلني.
Delirium has been described as, quote, a disturbance of consciousness with impaired attention and disorganized thinking or perceptual disturbance that develops acutely, has a fluctuating course, and with evidence that there's an underlying physiologic or medical condition causing the disorder. The condition has been recognized for centuries. In the 1600s, it was described by savants as mad in patches of lucid intervals. Delirium is caused by a combination of predisposing vulnerability factors and precipitating factors. Those predisposing factors include a previous diagnosis of dementia, advanced age, the male gender, a MMSE score of less than 24, a prior history of delirium, depression, alcohol abuse, untreated hearing or vision loss, needing assistance in 2 basic activities of daily living, current use of an anticholinergic, dehydration, sodium abnormalities, history of hypertension, CHF, diabetes mellitus, CVA, or AFib, or admitted for, in current circumstances, urgent surgical repair of hip fracture or elective aortic aneurysm repair. Precipitating factors include infection, injury, pain, hypoxia, hypoperfusion, electrolyte imbalance, recent surgery, use of physical restraints, malnutrition, sleep deprivation, immobility, dehydration, sensory impairment, using more than 3 new meds during hospital stay, bladder catheterization, urinary retention, fecal impaction, alcohol abuse, exposure to an iatrogenic event, acute medical emergencies including heart failure, myocardial infarction, shock, head trauma, seizure, stroke, or other subdural hematoma. Focusing in on for a second time those medications that can precipitate delirium: anticholinergics, TCAs, antipsychotics, anti-inflammatory agents, benzodiazepines, alcohol, digitalis, antihypertensives, diuretics, lithium, opioids, and GU drugs including ranitidine and cimetidine can all prompt onset of acute delirium. Delirium is usually acute in onset, of fluctuating nature and evolving course. Symptoms include attention disturbance, memory disturbance, orientation disturbance, perceptual disturbance, thought disturbance, sleep disturbance, consciousness disturbance, speech disturbance, and psychomotor activity disturbance. Modern-day standards for diagnosis are established by the DSM-4. Those criteria include disturbed consciousness, cognitive change, perceptual disturbance, rapid onset, and evidence of causal physical condition. The confusion assessment method, also known as CAM, is another standardized instrument developed for clinicians to identify delirium quickly and accurately. It can be used in clinical and research settings. The test helps to distinguish dementia from delirium. A diagnosis of delirium requires the presence of acute onset with fluctuating course, inattention, and either disorganized thinking or altered levels of consciousness. Other supporting features of delirium include disorientation, memory impairment, perceptual disturbances, delusions, psychomotor agitation, sleep cycle disturbances, and inappropriate behavior. When appropriate, a complete workup for delirium should go beyond standardized testing or criteria. Diagnosis should include a physical exam, a neurological exam, vitals, a review of medications, a review of alcohol abuse, assessment for Foley's, drains, IVs, monitors, restraints, and any other tethers, and certain labs including a UAUC, creatinine, sodium, calcium, and glucose. If the patient has had a history of recent head trauma, neurological changes, or encephalitis might be of suspect, then adding additional imaging is indicated. The key to treatment of delirium is identifying and removing or treating the underlying cause. In most cases, it is reversible. General measures to consider include maintaining safety, which can be accomplished by a professional sitter or just a familiar face at the bedside, environmental modifications such as continual orientation to new surroundings and providing things such as clocks and calendars, and helping keep patient areas well lit, quiet, and keeping the call light well and within reach. If appropriate, it may be necessary to discontinue any tethers on the patient as well, such as restraints or Foleys. Physical restraint should truly be used as a last resort. Be sure to identify and manage pain and constipation. Provide stimulating activity during the day, work to correct sensory deficits, promote sleep, and strive to prevent dehydration. From a pharmacological perspective, the starting point in delirium treatment should be discontinuing or decreasing any existing doses of hypnotics, psychotropics, or anticholinergics, or as well any other offending medications. At the point of agitation or aggression developing in the course of the illness, the use of trazodone or high-potency antipsychotics such as haloperidol should be considered. Patient status should then be reevaluated every 30 minutes. If the delirium is related to alcohol or benzodiazepine withdrawal, then the patient should be treated with Ativan and thiamine. Prevention of acute delirium is better than waiting for onset and valuable resources to be used. Strategies for prevention include early identification and removal or treatment of underlying causes. Many of the non-pharmacological treatments for delirium become the prevention strategies when utilized prior to onset. Families, of course, can provide a lot of that support. Bringing patients' personal items to the bedside, making sure that they have their hearing aids and glasses, and encouraging low stimulation visits are just a few of the things that families can do to prevent delirium.